Thank you very much. I'm not going to speak so much about what's happening in Sweden, but rather how Sweden is engaging globally to respond to what we now is seeing happening. But let me take a moment first to reflect back a bit. In 1995 to 1998, I was working in Zambia. At that time, there were no treatment. People were dying. The only thing that we could offer at that time were home-based care. 1996, UNAIDS was created. Sweden was part of that. In 2002, I was asked by some people to become the interim executive director for the Global Fund. Nobody believed that we would be able then to turn around this organization or to make this organization actually to deliver. In 3 months' time, we had a call for proposals, we had 11 meters of applications, and we had the first decision of the first round in April 2002. In 2003, I joined the team at WHO together with J.W. Lee, and I think we should remember what he did in terms of then challenging the world to say that 3 by 5 was possible. I still remember when he and Jim Kim came to me. I was in charge of general management at that time at WHO, and they said that they had persuaded the Canadian government to donate 70 million. And I was in charge of management, and I asked, where is the project document to support this? There was none. There was political vision and there was political commitment, and then we did the admin work afterwards. In 2006, J.W. Lee had just died, and I was acting Director General then for WHO. And again in Canada, Canada was hosting the International AIDS Conference in Toronto that year, and I was one of the speakers at the end of that meeting, and I spoke about the 3 M's: money, medicines, but that is not going to be enough. We need also motivated health workers. And we had people demonstrating there and said, we need the health workers. And that, I think, was the sign to say that it's not good enough just to have people on treatment, but we need also an effective system. So where are we today? I mean, we have heard the latest figures that 13 million people are today accessing treatment. This is a great achievement. We still have many people that are not accessing treatment, and we need to work hard on that. But what are the implications now in terms of having so many people on treatment, in terms of how we as governments, engaged people, are responding now to this to ensure that people then can stay on lifelong treatment? I have 3 messages. The first one is then around integration. And this is something that we've heard a lot about. We heard just President Clinton talking about a super efficient system, and he was referring also to the experiences in Rwanda. So what is Rwanda doing? They don't have an HIV/AIDS system. They have a well-functioning health system. They have community-based health care. They have an integrated systems for procurement distributions of drugs. They have health workers that are multi-tasked, that have responsibilities for HIV/AIDS, yes, but also for other issues. This is, I think, possibly one of the best examples we have, but it doesn't make sense to create separate systems. So we need to move now, according to what Michel Sibidi is saying, bring HIV/AIDS out of isolation, make sure that we now have a consolidated, sustainable response building on an integrated service delivery system, where we have health workers, where we have supply systems, where we have warehouses, not what I saw in Senegal just 6 months ago, that you had a separate room for the Global Fund drugs, and then you had the rest. It's not an efficient way of working. You need to build a system that is working in a seamless way. The second thing that we need to do, and again, this is something that we reflect a lot on from the Swedish side, is the financing, of course. We have been quite successful, I think, in the world to raise more resources. There's still a big gap, but the big shift now in terms of financing is not on the international side. The international resources are continuing to increase a bit, not dramatically, not as it did during the last 10 years, but it's still increasing. But what is dramatic is the domestic resources. So we see now much more of domestic financing. Domestic financing has taken over financing of HIV/AIDS in low and middle income countries. And if you look at the big picture in terms of financing of health in low and middle income countries, only 5% of that cost is coming from international resources. So let's not forget and get the perspectives right. The international resources are important. We need to continue to raise and to increase the resources. But what is important here is also to work in a more effective way also with domestic resources. As economies are growing, as we see them are doing quite rapidly in quite a few African countries today, we need also to ensure that governments are then increasing the spending then also on the social sectors. Some countries are not. We also have a big issue still in terms of what we call out-of-pocket expenditures, that poor people are paying themselves. In quite a few countries still, the majority of the resources are coming from people that are vulnerable, that are most at risk, and then they have to pay out of pocket just in order to be able to get health care. We need to get that kind of resources into systems where you share risk and where you share the burden of paying according to ability to pay. We need effective national health financing strategies where you take this into account, where you have international resources. Over time, you will have a phasing out of those and you will have a phasing in of domestic resources, but this needs to be done in a structured and organized way. The out-of-pocket expenditures, like what Rwanda has done, needs to be brought into some sort of health financing strategy and systems. Insurances or taxation, depending on countries, but still it needs to be brought into a system. In financing, we need also to make a stronger case for the investment, that this is it's not just a cost, but this is also an important investment for countries, for people, for companies, for families, in order actually to be able to get out of poverty and also to be able to get the kind of development we would like to see in countries. So we need to make that economic argument a little bit stronger than what we have done during the last years. And I think we can go back and see what has actually happened in at least some of the African countries, possibly not in the same way in the Asian countries, that the reason, what we have seen in terms of also economic development is partly because of the investments in health. Possibly one shouldn't push that argument too strong. I was listening to Jim Kim a couple of weeks ago in Washington, and people were talking a lot about the importance of using that argument to convince Minister of Finance to put in more money, to get more long-term sustainable financing for health and HIV/AIDS. But he said also that if I look back to what we did then in 2003, we didn't do this for an economic reason. We did this for a human reason because we believed in this and we believed that this was the right thing. We should always do the right thing and not just do the things because of economic reasons. But I think still it's important to understand what investments in health also means in terms of economic development. Finally, ARVs for lifetime, what does it mean also then for the global system? As the world is changing, as I said, countries today are then putting in more resources themselves. The role of international resources are changing. We have a different power balance in the world. What does that mean also in terms of what kind of international response we have? Quite a few people are discussing this today. What is the kind of international system we need? The title of this was the Global Health System. And this is something that we are quite engaged in and seeing, is it really fit for purpose? I don't think so. I think we need a system that needs partly to rethink and to be reshaped in order now to be able to continue and to respond here. And just to give a couple of thoughts here, that rather than just sort of thinking international systems is about money and that's it sort of, we need to rethink a little bit in terms of what are the functions of an international health systems to be able to respond now to a situation where we have people on treatment, where we have new diseases coming, where we are going to face people that are living longer, that are becoming elderly. So what kind of systems we need? We need a systems where we have norms, standards, knowledge, monitoring of trends, knowing what we're doing, being able to learn lessons. And that, I think, people are thinking of WHO here, and WHO has a core function to play. Possibly there is more to do in terms of how that then is delivered at country level. The second function of an international system is still, I think, is financial transfers. But I think here we need to be more strategic in terms of seeing in which context, where does international money matter, and what is international money, international resources spent on. And the international system is not 100% tuned today to make the best possible investments in the different country context. Possibly also there are new functions for international systems, which has more to do with global public goods. The negotiations of prices, the negotiations of access, which we are talking about today, but I don't think we are really cracked in terms of how can we now ensure that people have access now to the new drugs, best quality. Another function here, and possibly we need international functions that are more in terms of negotiating. And we need also different kinds of accountability at the global level. That's still a vague thing. We speak about accountability, but it's not crystal clear what we mean. But finally, possibly the most important thing in terms of a health system, enabling people to stay on ARVs, enabling countries to afford this, that is, of course, to avoid new infections. We haven't spoken, I think, enough about that here. Some countries, and we heard examples here also from President Clinton, are not in a positive trend. I was quite worried having a long talk to the Minister from Health from Uganda. Uganda was a success story. Now the development in Uganda is not so positive any longer. And the projections in terms of the costs for Uganda is quite frightening. What is most important here is, of course, yes, ensuring that people have access to drugs and they will survive, but just as important is also to ensure that we rapidly increase our efforts to ensure that less people are getting infected. Thank you.
Thank you, Dr. Nordstrom.